Muy buenas tardes a todos. Es un honor para mí presentarles al Dr. Timothy Pollick, quien pronunciará la próxima conferencia magistral. El Dr. Pollick realizó su entrenamiento quirúrgico en la Universidad de Michigan y realizó un fellowship de investigación en cirugía oncológica en el Massachusetts General Hospital. Posteriormente realizó una subespecialidad en cirugía oncológica en la Universidad de Texas MD Anderson Cancer Center en Houston. Además, el Dr. Pollick tiene un interés particular en ética médica, por lo que realizó un fellowship de ética médica en la Escuela de Salud Pública de Harvard, así como una maestría en teología en la Harvard Divinity School en Boston. Además, recibió un doctorado de investigación clínica en salud pública por la Universidad Johns Hopkins. Actualmente, el Dr. Pollick es el jefe de cirugía en el Centro Médico Wexner de la Universidad de Ohio. Ha dado más de 300 pláticas, tanto nacionales como internacionales, en 25 países diferentes, y ha publicado más de 600 artículos y 50 capítulos de libros. Es editor asociado de varias revistas como Annals of Surgical Oncology, Journal of Gastrointestinal Surgery y The JAMA Surgery. También es miembro de múltiples sociedades como la Sociedad de Cirugía Oncológica, la Asociación Quirúrgica Americana, la Sociedad de Cirugía Clínica y actualmente es el presidente de la Asociación Hepato-Pancreato-Biliar de las Américas. Sus principales intereses clínicos son en enfermedades hepáticas, pancreáticas y de vías biliares. En esta ocasión, el Dr. Pollick nos hablará de colangiocarcinoma intrahepático. Muchas gracias por acompañarnos el día de hoy, Dr. Pollick. Bienvenido.
Good morning. Thank you for the opportunity to discuss with you the clinical approaches to intrahepatic cholangiocarcinoma. I'm happy to be joining you virtually today to talk to you about this important topic. As you know, the incidence of cholangiocarcinoma varies dramatically geographically across the world. Whereas in the United States, the incidence is only in the range of about 1 to 2 per 100,000. In Eastern countries such as China, the incidence can be significantly higher. You can see here in Shanghai, the incidence of cholangiocarcinoma is about 7 to 8 per 100,000. And in other countries in East Asia, such as Thailand, the incidence can be extremely high as 85 per 100,000. The reason for this is multifactorial and likely relates to environmental exposures, including hepatitis and liver fluke worms in such countries as Thailand. As I noted, there's many different risk factors for intrahepatic cholangiocarcinoma, and these include environmental factors such as hepatobiliary flukes, primary sclerosing cholangitis, and choledochal cysts, all of which are somewhat more common in Eastern countries. And then there's other risk factors, including obesity and diabetes, that are more common in Western countries where there is an epidemic of obesity, NASH, and NAFLD. Over the last several decades, there has also been a much greater understanding of some of the genetic underlying molecular pathogenesis of this disease. We have been studying this disease extensively over the past 10 to 20 years. This is one study in which we saw that patients with steatohepatitis and steatosis were at significantly higher risk of developing intrahepatic cholangiocarcinoma. And you can see this here in this liver on the right that is replaced by fatty adipocytes, that these patients are at much higher risk of intrahepatic cholangiocarcinoma, likely due to the oxidative stress from the fatty deposition. As I mentioned, there's been much greater understanding of the molecular pathogenesis of this disease and the different pathways that may be involved in the development of intrahepatic cholangiocarcinoma. Our group has similarly done work on this topic. This is a study that was published using our international multi-institutional database of resected intrahepatic cholangiocarcinomas. In this study, we did a genetic mutational analysis of the specimens that were resected. And what we found that in using this tissue array, that there were no somatic mutations in about 2/3 of patients. Those patients who did have mutations, however, most commonly had mutations in the common genes that are mutated for GI tumors, including KRAS and BRAF. And then interestingly, as many others have shown, the most commonly mutated gene was IDH1 or IDH2, which was mutated in about 15 to 20% of patients. These genetic mutations are important because they can have prognostic implications. As can be seen here in this study, those patients who had mutations in KRAS or BRAF had a significantly worse long-term outcome. In fact, the median overall survival following resection was less than 2 years. Similarly, mutations in IDH can also have prognostic implications. In this study, we see that patients who had a mutation in IDH had a median survival of only about 2 years, which was significantly shorter than those patients who had a wild-type IDH. There's also been much interest around immunotherapy, and we have performed studies looking at PD-1 immune checkpoints in intrahepatic cholangiocarcinoma. And indeed, a subset of patients will stain positive for PD-1, suggesting that a subset of patients indeed may be amenable to immunotherapy. Well, these patients typically present with an asymptomatic tumor in their liver. It is not infrequent that a patient may present with vague symptoms and have a CT scan that demonstrates a large tumor in their liver, as can be seen here. Typically, the tumor is then biopsied and it comes back as adenocarcinoma. It's important to note that there are no reliable markers to differentiate intrahepatic cholangiocarcinoma from a metastasis from another primary. Typically, the pathologist will look for biliary dysplasia, and this will be a diagnosis of exclusion. Immunohistochemical stains are very important, and a good hepatopathologist can help you differentiate an unknown primary with metastatic disease from the liver versus a primary intrahepatic cholangiocarcinoma. Typically, we look for IHC staining that is negative for TTF1, CDX2, and DPC4, and IH staining that is positive for those markers consistent with biliary epithelium. It's also important to note that there are different morphologic subtypes of intrahepatic cholangiocarcinoma. In particular, the mass-forming type, which is the most common at 70 to 80% of all intrahepatic cholangiocarcinoma, typically presents as a homogeneous lesion that is low attenuated, and it can be seen with capsular retraction and then peripheral enhancement. The second morphology is the periductal infiltrating morphology, which is characterized by periductal enhancement and thickening and dilatation of the intrahepatic bile ducts. The third morphology is the intraductal growth pattern that is characterized by diffuse marked duct ectasia, with or without a visible papillary mass within the biliary tree. With good cross-sectional imaging, one should be able to differentiate an intrahepatic cholangiocarcinoma from a hepatocellular carcinoma. On cross-sectional imaging with contrast-enhanced CT, an intrahepatic cholangiocarcinoma will appear as an irregular low attenuation mass that is hypodense on the early phases and then hyper-enhancing on the later phases, which is typically the opposite of what you would see with the hepatocellular carcinoma. You can also look for peritumoral ductal dilatation. At our institution, we use a lot of MRI. And this sequence of MRIs shows some of the classic features for intrahepatic cholangiocarcinoma. A hypodense mass with capsular retraction, a necrotic center with enhancement on later phases of the rest of the tumor, and then some peritumoral ductal dilatation. And this is very consistent with an intrahepatic cholangiocarcinoma. In my practice, I tend to use a fair amount of PET when working up patients with intrahepatic cholangiocarcinoma. This is a very FDG avid lesion, and in about a third of cases, you might discover other sites of disease and or identify FDG avid lymph nodes that would direct my treatment. As I noted, we've done a lot of work on this disease over the past 20 years with our collaborators throughout the world, including in China. And this is a very difficult tumor to treat surgically. Typically, these masses present later. They tend to be large in nature, requiring a major hepatectomy. As can be seen here, this is a patient with a large central tumor that abuts the umbilical fissure that's occluding the right anterior posterior sectoral branch and abutting the right posterior sectoral branch. This patient required an extended right hemihepatectomy, and here you can see the main portal vein and the cut edge of the right portal vein. You can see the bile ducts to segments 2 and 3. And this is the explant with the gallbladder in block. And you can see how these tumors are very large typically, requiring a large resection, and then not infrequently a close surgical margin. So it's important to note that margin status is important in resecting patients with intrahepatic cholangiocarcinoma. Our group and others have demonstrated repeatedly that those patients who have a negative surgical margin have an improved long-term survival relative to patients who have a close and or positive surgical margin. But even with a negative margin, this disease has a grave prognosis. This is a study that we published in Cancer that demonstrated that even patients who undergo a curative intent surgery with negative surgical margins, that the overall probability of cure is still only in the range of about 10%. And you can see that the risk of recurrence is quite high and also quite early. Therefore, it is important to be able to prognostically stratify these patients. And until the 6th edition AJCC manual, we really had no way to effectively stage patients with intrahepatic cholangiocarcinoma. I'm happy to report, though, in the 7th edition, based largely on some of the work from our group, the AJCC did introduce a new staging system for intrahepatic cholangiocarcinoma. And this staging system was just most recently updated in the 8th edition AJCC staging manual, whereby T1 tumors are tumors, T1A tumors are single tumors that are less than 5 centimeters, T1B tumors are greater than 5 centimeters, and T2 tumors are those tumors that have either vascular invasion or are multifocal in nature. And this new staging system updated in the 8th edition manual has been validated by our group and others. Well, what about lymph nodes? Lymph nodes have been a topic of much discussion. We typically do a lymphadenectomy for patients who have fibrolamellar hepatocellular carcinoma or gallbladder cancer, but we don't do a lymphadenectomy for those patients who have so-called garden variety hepatocellular carcinoma. So should we be doing a lymphadenectomy for patients with intrahepatic cholangiocarcinoma? Well, if you look at data from our group, you can see that around 500 patients who were treated at centers from around the world for intrahepatic cholangiocarcinoma, only roughly half had a lymph node dissection performed. And among those patients who had a lymph node dissection performed, 3 lymph nodes were harvested in general. If you look at the overall incidence of nodal disease, it was about 30%. And even if you considered all the patients who did not have a lymphadenectomy, who were NX to have N0 disease, the incidence of lymph node disease would still be about 20%. And we know that lymph node status is important to prognostically stratify patients. Patients who have lymph node disease do significantly worse than those who are node negative. And we also know that it is nodal disease that drives someone's overall prognosis if they indeed have lymph node metastases. And you can see here that in those patients who have N1 disease, the relative prognostic importance of vascular invasion and single or multifocal disease is not as important as it is among those patients who have no nodal metastases. And therefore, we feel strongly that it is important to harvest the appropriate nodal basin at the time of surgery. And these data demonstrate that the location of the tumor should dictate the nodal basins that are dissected at the time of surgery. And we can see here that in left-sided tumors, nodal basins 1, 3, and 12 should be the primary groups that are harvested. And in comparison, and when the tumor is on the right side of the lesion, nodal basins 12, but then also 7, 8, 9, and 13 should be harvested. In the current edition of the 8th AJCC manual, it is noted that one should try to harvest at least 6 lymph nodes to ensure accurate staging. However, we can see here these data from the United States that unfortunately lymphadenectomy is still only performed in roughly half of all surgeries for intrahepatic cholangiocarcinoma, and it remains difficult to harvest 6 lymph nodes, with many centers harvesting significantly fewer lymph nodes, therefore risking understaging of the patient. Well, I've discussed with you that the outcome for patients who undergo curative intent surgery for intrahepatic cholangiocarcinoma can be quite poor. And the reason for that is that patients recur. Many patients recur, and patients tend to recur early. In our data, we saw that over half of patients recurred within 19 months of their surgical resection. And if you look, half of patients had an extrahepatic site as one of the areas where they recurred, suggesting that this is a systemic disease in many cases. And if you look at the risk of recurrence, it's very high among those patients who have multiple tumors or those patients who have lymph node metastasis. And this is why in patients who present with multifocal disease and lymph node metastases, I typically would treat these patients with preoperative chemotherapy prior to taking them to surgery. And if you look at where patients recur, you can see that 1/3 of patients recur in the nodal basin. And that is another reason why I believe in performing a lymphadenectomy, because not only does it provide important prognostic information, but you can decrease the risk of local regional recurrence in those nodal basins. Since recurrence is so common, it's important to discuss chemotherapy. These are data from the ABC trial, which is a trial that looked at inoperable advanced biliary cancer and looked at patients who were randomized either to monotherapy with gemcitabine versus doublet therapy with gem-cis. And in this study, the time to progression and progression-free survival was significantly better in those patients who were treated with doublet therapy gem-cis. And therefore, gem-cis has been the traditional chemotherapy regimen used for patients with either advanced disease or even in the adjuvant setting. More recently, there have been several prospective adjuvant trials looking at chemotherapeutic regimens for patients in the postoperative period following resection. And in particular, the BILCAP trial, which looked at placebo versus capecitabine in the adjuvant setting, was interesting because it noted a significant decrease in the chance of death for those patients who were treated with capecitabine versus observation. However, a separate study in Europe, the Protégé 12 study, which looked at gem-ox versus observation in the adjuvant setting following resection of biliary tract cancers, failed to show a survival benefit for adjuvant gem-ox. It's hard to interpret why these studies were so different in their findings, but it is important to note that the majority of patients in the Protégé 12 study were node negative and had an R0 resection. Therefore, perhaps it is that only those patients who are at high risk, i.e. node positive or R1 resection, benefit from adjuvant therapy. The role for radiotherapy, I think, is much more limited for this disease. There are some open prospective trials looking at stereotactic beam radiation therapy for patients with inoperable tumors, but typically I do not use radiotherapy in the adjuvant setting. I do think that there is a role for intra-arterial therapy in certain circumstances. For patients who have inoperable disease, radioarterial therapy or chemoarterial therapy can be a good adjunct to systemic chemotherapy to get better control of the intrahepatic disease to prolong survival. So with that, I'd like to conclude. Hopefully what I've shared with you today is that intrahepatic cholangiocarcinoma, the incidence is increasing, that this is a grave disease with a high case rate for fatality, that surgery remains the cornerstone of therapy for these patients. However, novel therapies, including better systemic therapies and targeted therapies, are needed if we are to improve the outcomes of patients with intrahepatic cholangiocarcinoma. Once again, I'd like to thank you for this opportunity to be with you virtually.